Unplugged. We are very excited to have you here with us for the first session of 2021, and many thanks to those of you who were able to participate in last year's meetings. As you guys know, typically we'll do some complicated patient clinical situations, but to keep things fresh and relevant for this first session, we really thought we would do a disservice to you to not acknowledge the pandemic going on in the world right now, and to look at that intersection that may have for all of you all in the TB clinics or the public health clinics where you may be serving. So with that, we'll get started off with our session titled Leading Your TB Colleagues, Staff, and Patients to and Through COVID-19 Vaccination, a conversation with experts. We have an exciting panel for you today as speakers with Colleen Kelley from the Emory Vaccine Center, Sarah Mbaeyi from CDC's National Center for Immunization and Respiratory Diseases, and Dick Bergstrom from Operation Warp Speed and CDC. But before we go to Dr. Kelley, we just wanted to, as we usually do, ask you all to participate with a question to start off. So hopefully you all see this question showing up in your polling box. The TB nurse at your clinic asks you for advice. She knows that a COVID vaccine is available for healthcare workers, but is anxious that it got approved so quickly. Your TB nurse asks you, should she wait for other people to receive it first? What do you tell her? And if you guys can just pick which of these options you would choose, given where you are, and we recognize you all have a variety of experiences, some in COVID response, some 100% in TB, some in lots of different spaces. First option here, you're really comfortable with the science behind the vaccine trials. Unless she has a contraindication or specific condition she's worried about, she should get it. Then she should get it right away. Option B, it's complicated, and you agree with her. Better to wait for at least a couple months. See what happens to other people first. Option C, you tell her you prefer not to give an opinion. Better for her to look at some CDC and local health department resources and talk to her healthcare provider. And last option, something else. And we'll go ahead and as folks are joining in, we'll keep the show going here. And at least it looks like about a little over 3/4 are going here with our first option. I'm going to go ahead and show you all what you and your colleagues are answering here. So it looks like about 75% are pretty comfortable with the vaccine, but we've got a quarter saying, you'd really prefer not to give an opinion right now. Maybe there's some more things that either you should do or she should do before any advice is really given. So with that, I want to go ahead and actually start off by introducing Dr. Colleen Kelley. She's an associate professor of medicine in the Division of Infectious Diseases at Emory University School of Medicine and co-director of the Emory Center for AIDS Research. She leads HIV prevention clinical trials for the HIV vaccines trial network at the Hope Clinic. And in response to the COVID pandemic, she expanded her focus and now leads the Moderna and Novavax COVID vaccine efficacy trials at the Ponce de Leon Clinical Research Site here at Grady Memorial Hospital in Atlanta. Thanks, Dr. Kelley. With that, I'll hand it over to you.
Thank you so much, Neela, and thanks for the opportunity to share my experience with these very exciting and fast-moving clinical trials that we are participating in. So I will go ahead and get started with that. These are my disclosures, all research-related grants to my institution. So back early in the pandemic in the spring, we started looking at how long would it really take us to get a COVID vaccine. Traditionally, it takes years and years and even decades from the time of identification of an infectious agent to the development of an effective vaccine. And you can see that here in this chart from the New York Times. The goal in the beginning of the pandemic was to get to an effective COVID-19 vaccine within a year and a half, and we far surpassed that. in speed, which is just an amazing feat of science. So to tell you a little bit more about the data behind that and how that happened, I'll just briefly kind of review that. Typically, vaccines and all products that reach FDA approval in the United States follow a very typical sequential development timeline. So preclinical development in animal models then go into phase 1 trials, followed by phase 2 and 3, and then finally implementation. And that's why things take years and years and decades. There's a lot of resources, a lot of thought, and a lot of care that goes in each of these steps. This clearly wasn't going to be feasible to follow the traditional vaccine development timeline for COVID vaccines if we were going to get there within a year. And so Operation Warp Speed, as you all may be familiar with, and I understand that term is being retired by the Biden administration, but this was the multi-governmental agency plus academic plus industry partnership to ensure that vaccines could be accelerated and reached on that very quick timeline. And here in this chart, they were looking at 14 months to completion. So the way that they did that was, instead of doing vaccine development in the typical phased sequential development, these steps were done in parallel instead of in sequence. So at the same time the phase 1 trial was being conducted, planning for the phase 3 efficacy study was already far underway, such that the moment the phase 1 safety data were available, the phase 3 efficacy trial launched. And then, even more amazing, while the phase 1 trials were being conducted, the vaccines were already being mass produced, such that the moment efficacy data and FDA emergency use authorization was released, the vaccines could be deployed. And that's what we've seen happen in the last month or so. And so this was just really a testament to, with the appropriate resources and manpower, how vaccine development could be tackled in the setting of a pandemic. So obviously this takes an enormous amount of money. Operation Warp Speed selected 6 vaccines from 6 different companies to pursue in their portfolio. There were 2 vaccines each from the messenger RNA portfolio that we'll talk a little bit more about, 2 from the vector-based vaccines that we'll talk about, as well as 2 from the protein-based vaccines that we'll talk about. This cost billions and billions of dollars. And it's not just the money, though. It's the commitment from the scientific community. It's the commitment from industry, and it was a commitment from academic partners as well, all to kind of tackle the pandemic. So of the 6, 5 of the 6 are in efficacy trials. 2 have already reached their primary endpoint. The Janssen, those are the Pfizer and the Moderna vaccines. AstraZeneca met its primary endpoint in the UK, not yet in the US. We're anticipating an announcement from Janssen in the next week or two with their primary efficacy results. And then the Novavax trial launched in December. The Sanofi and GSK vaccine, which is a protein-based vaccine, had some issues starting up. And so we're anticipating that that will open in the springtime or so. But from the beginning, the US government fronted money for millions and millions, hundreds of millions of doses of these vaccines. So this is from the New York Times, the coronavirus tracker, just to tell us how many vaccines were in development. They used to have, in the beginning, they used to have a preclinical phase here, and there were hundreds of vaccines in preclinical phase. But this can tell you how many vaccine candidates are currently in phase 1, phase 2, and all the way through to approved. In the US, these are emergency use authorization approvals. These are not full FDA approval, and so that's something to be aware of. And in other countries, there are other vaccines besides the 2 that we have for emergency use authorization, the Pfizer and the Moderna vaccines, that are in limited use outside of the US. So I talked a little bit about some different vaccine types, the 3 different vaccine types that are in the Operation Warp Speed to be, I guess, renamed portfolio. But when we think about vaccine development, just taking a step back, there are several different types of approaches that scientists have used over the years to approach infectious disease vaccine development. All of these were tried or being tried for development of COVID vaccines. The first are whole virus vaccines, and these can either be killed or live attenuated. You may be familiar with these with the MMR vaccine, the varicella vaccine, or yellow fever vaccines are all examples of these whole virus vaccines. Subunit vaccines, which are the more traditional approach to vaccination, where we take a piece of the virus or a protein or a toxoid piece of the infectious agent, the virus or the bacteria, and inject that to generate an immune response. And we are familiar with hepatitis B, HPV, and tetanus vaccines that use those methodologies. Vectored vaccine, there's only one that's been approved, and that's the Ebola vaccine, the VSV vaccine, and those can be either replicating or non-replicating. These are taking another virus. In the example of of the Ebola virus, it's a VSV vector. In COVID vaccines, we have the chimp adenovirus, which is the AstraZeneca product, and the Janssen product, which is adenovirus 26, and where inserts are placed into those vectored vaccines of the COVID-19 vaccine in order to generate the immune response. And then for the first time, we had nucleic acid vaccines, messenger RNA vaccines reach efficacy trials, and those are both the Moderna and the Pfizer product. So two have emergency use authorization, but none have full FDA approval for use. And so really the COVID pandemic has allowed us to accelerate vaccine development, but also finally implement and try new things that were so promising. And so for COVID vaccine development, scientists decided early on it was that S protein that they should target to develop an immune response to. This is a cartoon of the COVID virus, and that S protein that kind of sticks out like a lollipop on the surface of the virus. And scientists knew from studying MERS and SARS-CoV-1 that this was likely to be where the money was. And so all of the vaccines in the Operation Warp Speed portfolio are focused on developing an immune response to this S protein. And so just to tell you a little bit more about how this was decided upon. So we first heard about the COVID cases in December, and then a few weeks later, just a few weeks later in January, we already had the genetic sequence from China of this new pathogen. Based on the genetic sequence and based on the knowledge that it was a coronavirus and the research that had gone into MERS and SARS-CoV-1, scientists picked out that sequence of the spike protein as the likely spot that we wanted to target to develop an immune response. Soon after that, in March, the cryo-electron micrograph structure of the spike protein, which you can see here, was released. And that enabled scientists to begin to do protein-based vaccine development. So the genetic sequence led to us being able to, scientists being able to make messenger RNA as well as vector-based vaccines, and then knowing the spike protein structure enabled scientists to then move forward with protein-based vaccines. And all of this happened on such a rapid, amazing timeline. It's just really hard to fathom how quickly these findings were discovered. So just to take a step back, and I think maybe these are all household names by now, but messenger RNA vaccines, how do they work? So messenger RNA is basically a small genetic sequence. I told you scientists figured out what the sequence to the spike protein was. And so then they created messenger RNA or synthesized messenger RNA in the laboratory that could be injected into human beings, taken up by muscle cells. And the messenger RNA tells the muscle cell to produce that spike protein, tells the body to make that spike protein that then allows the body to form an immune response to it. None of these have FDA approval to date, although two have emergency use authorizations. And given the advances in science in the last 10 years or so in messenger RNA technology, messenger RNA has become fairly quick and easy to make, which is why those vaccines were first in line to enter clinical trials and first in line to be approved, because it was so quick once the genetic sequence was known to be able to make messenger RNA. Messenger RNA, however, is very fragile and it rapidly degrades, which is kind of a good thing when we think about making a vaccine. The product rapidly degrades in the human body, but it does require some cold chain storage. And I think we've all heard about that, particularly with the Pfizer vaccine requiring these ultra cold -70 Celsius storage temperatures for maintenance of vaccine integrity. And these vaccines, messenger RNA vaccines, were being pursued already for Zika, for rabies, for influenza, for SARS-CoV-1 and MERS, as I said. And in addition, they are also being pursued as cancer vaccines to try and eliminate cancer cells in the body. And so they were poised for prime time when the COVID pandemic hit. And that was really, really fortunate for all of us. So a little bit more on how these vaccines work. So in here in green, and these are the New York Times cartoons that I've taken here and cited here at the bottom. The New York Times has just done an amazing job at simplifying very complex scientific principles during the COVID pandemic and making nice infographics. So I've just lifted them from there here to share with you. These are the vaccine particles that are injected into the muscle, and they're taken up by the muscle cell here. And then the messenger RNA is translated at the ribosome into the spike protein. The spike protein is then expressed on the cell surface where both arms of the immune system, both the antibody response as well as the T cell response is generated through B cells as well as I said, T cells. B cells ultimately make those antibodies and most importantly, those neutralizing antibodies that we think are essential for vaccine response, as well as the T cell response that continue to help the B cells make good antibodies, but also can identify infected cells and kill those infected cells. Both arms of the immune system likely important in protection from COVID-19. So I was involved with the Moderna mRNA vaccine as a site principal investigator. And just when we review the timeline for how this happened, it's just stunning. So as I said, in December were the first reports of this new pathogen, this new respiratory virus outbreak. By January 10th, this coronavirus sequence, the novel coronavirus sequence was published, which is just amazing. And then 3 days later for the Moderna vaccine, they chose the spike protein sequence that they were going to synthesize to use in clinical trials to generate that immune response. So by March, the phase 1 clinical trials for the Moderna vaccine were launched. And then by July, we were in phase 3 efficacy trials. So just a stunning timeline, really, really amazing to think about. So just to review again, the vaccines that are currently in phase 3 clinical trials in the US, I mentioned the Pfizer and the Moderna vaccines, both messenger RNA platforms. They both showed good safety and immunogenicity data in their phase 1 clinical trials. Both already have emergency use authorization, as I think we're all very well aware. These vaccines do show some reactogenicity. All of these vaccines do, and we're going to talk a lot more about that in a few slides. But it's something just to be mindful of. The AstraZeneca and Janssen vaccines are the 2 vector-based vaccines that are in efficacy trials here in the US. The AstraZeneca vaccine is a chimpanzee adenovirus vector. It's a 2-dose regimen, as similar to the Moderna and Pfizer vaccines. The Janssen vaccine is an adenovirus 26 vector. And what's important about this Janssen product is it's a single-dose regimen. And so we eagerly await those efficacy data to see if a single-dose regimen will be sufficient. Novavax just opened at the very end of December. It is currently enrolling. The other trials have closed to enrollment. This is a protein-based vaccine with an adjuvant, and it also has very good safety and immunogenicity data, probably the best immunogenicity data we've seen so far. And so we hope that that trial is also successful here in the US. As I said in the beginning, the Sanofi trial is a little bit further behind because of some problems they've had, but we're hoping that that can launch later this year in 2021 as well. And so I'm going to pause for an audience response question.
Thanks, Colleen. And while that's loading up, oh, here it is. Well, for those of you on, have you received 1 or more dose of a COVID vaccine? If you've had a first dose, if you've completed a series, give us a sense of where you are at in this real-time process. And folks, please feel free to keep on putting questions in the chat, and we might try to address them here at the end in our discussion period. But I will go ahead and share what we've got so far. It looks like we're about over 65% have started on some kind of COVID vaccine series, but about a third have not. And so we'll keep marching ahead.
All right, that's fantastic. Glad to hear so many people have been able to access a vaccine already, and hopefully everyone else will too as well. So I've talked about the kind of 6 different candidates. We have 2 in EUA. So people ask me all the time, which of these candidates is the best? And I don't think we have a clear answer on that. And what I hope we have is lots of good vaccines. So all of these vaccine candidates in phase 3 have shown good neutralizing titers. What we don't know yet is how high the neutralizing antibody titers need to be for protection. Hopefully that's something that additional data will tell us. Early on, we were concerned about antibody-dependent enhancement or vaccine-associated enhanced respiratory diseases, because those were seen with some earlier coronavirus work and RSV as well. But in the presence of good neutralizing antibody titers as well as Th1 skewed T cell responses, that seems to be less likely, and there's been no evidence of this vaccine-associated enhanced respiratory disease in the trials so far. And so we think these vaccines are producing a good, strong immune response that prevents that from happening. All 5 of the 6 require the 2 doses. As I said, the Janssen vaccine is the one exception to that. All of them have acceptable side effect profiles so far, and we're going to talk a little bit more about that. That does not mean they're not reactogenic vaccines, because they are reactogenic vaccines, but we accept that the level of reactogenicity that we're seeing. We don't know yet how long immunity will last. It does appear that natural immunity is long lasting on the order of many, many months. And it appears that vaccine-induced immunity will be similar, if not better, to natural immunity. We're still waiting to know how the vaccine performs in pregnant women, immunocompromised people, and children. Lots of pregnant women and immunocompromised people have already gotten the vaccine, and so we will be getting data on that very soon. People who have already had COVID are eligible and should proceed to get the COVID vaccine, because there is some indication that the vaccine-induced immunity may even be better than natural immunity. We don't know yet for sure, but we don't know how people who have already had COVID before and symptomatic COVID respond to the vaccine, and so we're waiting for that. We do have the issues with the cold chain storage with the messenger RNA vaccines that we've talked about, and then of course cost. This is a very costly adventure, and we need to ensure that it's sustainable for the long term, but also across the globe. And so one thing that became very obvious early in the pandemic is that underrepresented minority communities of color were being hard hit by the COVID pandemic. And so we needed to ensure that those people who are most likely to benefit from the vaccine were given access to the clinical trials. We needed the clinical trials to represent the US population. A vaccine could potentially perform differently among underrepresented minorities, and we'll talk about that in a little bit. But more importantly, those who are going to benefit most deserved access to the vaccine clinical trials and should be overrepresented in the clinical trials. It's not until we ensure this with every single clinical trial that we do that we will right the historical wrongs that have occurred in research, and this is how we are going to build trust in the results. So when we think about why a vaccine might perform differently under underrepresented minority groups, we're not talking about genetic differences necessarily, or even specific biologic differences. What we're talking about is the confluence of structural racism that leads to adverse health outcomes. So when we think about a group of people that are more likely to suffer from segregation, from poverty, from decreased access to healthcare, we know those all of those things together will contribute to adverse health outcomes, and vaccine efficacy is absolutely one of those adverse health outcomes. And so when we're thinking about underrepresented minorities as a group and vaccine efficacy, it really, really just harkens back to the horrible impacts of structural racism in our society. And so that is why we needed to work hard to ensure those folks were represented in the clinical trials. So Dr. Fauci told us there was a way that we could end these clinical trials early, and he was right, as he almost always is. And so I'm going to tell you a little bit about how some of these trials ended in November. So basically every Monday morning in November, those of us engaged in the clinical trials, our cell phones were blowing up with texts, with DMs, with everything, talking about just the amazing, fantastic news we were waking up to early in the morning. Unfortunately, as is with the COVID pandemic, we were learning about these things at the same time as everyone else by press release on CNN and MSNBC and Twitter. But nonetheless, it was still thrilling to see these results. So Mondays in November, Pfizer on November 9th and then Moderna on November 16th released their initial efficacy results. They had enrolled 43,000 and 30,000 people in their trial respectively. Both showed greater than 90% efficacy across all subgroups in their COVID vaccine in prevention of symptomatic COVID disease. So the Pfizer vaccine was first to the goal line, but Moderna followed quickly thereafter. And these were based around a little bit less than 200 cases in each clinical trial. I will tell you that these clinical trials have continued follow-up, and they have amassed many, many more cases of symptomatic COVID disease since this time. And so we await updated efficacy result numbers from both of these companies. Pfizer promised us many million doses in 2020 and upwards of 1 billion doses in 2021. Same for Moderna. As we're all seeing play out in the rollout, we'll hear more about later. It's not exactly clear how these numbers matched up, but they certainly are getting into people's arms, and that's fantastic. Uh, the Pfizer vaccine does have some significant cold chain storage issues, as we talked about, compared to the Moderna vaccine that does require some freezer and refrigerator temperatures, which can be difficult as we think about implementation in resource limited settings. And both got their emergency use authorization in December, and vaccines went into arms shortly thereafter. Um, so these are those amazing efficacy data that were published in New England Journal. We see these Kaplan-Meier curves, and the curves just begin to diverge so significantly right after a week after the first vaccine, which is just stunning to see. But what we also learned from these vaccine clinical trials is that these vaccines are fairly reactogenic, that injection site reactions, fatigue, headache, muscle pain, aches, fever are fairly common in the first 1 to 3 days after getting the vaccine. However, severe reactions are very uncommon, are very rare, and there's no imbalance in serious adverse events in either of these trials. And so this is also the Moderna vaccine efficacy data as well. And it similarly showed amazing, amazing efficacy soon after the first dose, and then further separation after the second dose in those Kaplan-Meier curves. Also showed significant reactogenicity with injection site pain, fatigue, headache, and muscle pains and chills being very common after the vaccine. Again, in the first 1 to 3 days, mostly mild to moderate and going away on their own, and no imbalance in serious adverse events, which was just amazing to see. I mean, and no one could expected anything as fantastic as these results that we saw from the early Moderna and Pfizer analyses. AstraZeneca also released an interim analysis in December, which was a little bit more confusing. So this is a multinational trial, and they enrolled people in the UK, in Brazil, and South Africa. And they showed an overall efficacy of their chimpanzee adenovirus vector of 70%. It was a little bit confusing, though, when they did some subgroup analyses. They found that there was a mistake in participants who in the UK that received a half dose followed by a full dose. And that group showed 90% efficacy compared to when they analyzed the data for people who got full dose followed by full dose that only showed 62% efficacy. I don't think anyone really understands what's going on with this, but we do know that this does appear to still be an effective vaccine and is being used in the UK currently. This dose was also well tolerated. Ultimately, I think for the US, there's more questions and answers about this vaccine, and we await the results of the US-based trial before kind of any further movement goes on this vaccine. What's great about this vaccine is it's extremely cheap, and it does not require that cold chain, ultra cold storage, and so it will be easy to implement across the globe. Especially in places with limited resources because of its storage requirements. And so we cannot write this vaccine off yet by any stretch of the imagination, but there are some questions that we need to get answered about this vaccine. So vaccine safety. So let's take just a couple of minutes to talk about this. I hear this a lot from people. Don't we need long-term vaccine safety data? These vaccines were approved for emergency use authorization with about 2 months of safety data, median follow-up time. And a lot of people have said they won't get a COVID vaccine when it becomes available because they're not sure about safety. Well, vaccination is exceptionally safe. There are very few, very rare adverse events that have scientific evidence to prove or to associate their occurrence with vaccination. They're listed here on the slide, and you can see that they are exceedingly rare and mostly associated with a certain vaccine type or a certain patient population. So in general, vaccination is extremely safe. The other thing to know is that most side effects from vaccines are picked up within 6 to 8 weeks after the vaccine is delivered. And that is why the FDA asked for 8 weeks of follow-up prior to issuing the emergency use authorization, because in general, that is when we see side effects to vaccines occur. One thing I will highlight is anaphylaxis, because I think you've heard about that in the news quite a bit. Anaphylaxis can occur after vaccination. It's estimated to occur 1 in 100,000 to 1 in a million doses delivered. We're still waiting to hear on the Pfizer and Moderna vaccines how common anaphylaxis is, but it likely occurs in the range that is presented here on this slide. That is, it has been known to be associated with COVID vaccination. So we await additional data on that. The rest of these medical conditions are extremely rare, as I said, and usually associated with a single vaccine or with a certain patient population. Many other things have been examined for their association with vaccination. There does not appear to be any association for long-term side effects of vaccines with the conditions listed on this slide have been looked at for their association with vaccination. So a lot of things I hear about from people are infertility, diabetes, late or long-term side effects that could occur, and there is no good evidence that any of these things are associated with vaccination. And so people should rest assured. Of course, autism, I should bring that up as something historically that caused quite a conundrum with some falsified data. There is no evidence that any of these things are associated with vaccination, so people should rest assured that long-term side effects should not be an issue when we're thinking about vaccines. So I just wanted to revisit this a little bit. So in vaccinology and vaccine clinical trials, we generally allow for some level of reactogenicity, because reactogenicity means your immune system is doing what it's supposed to do. Your immune system is responding to the vaccine. So things like sore arm, muscle aches, fatigue, headache, sometimes some fever, nausea, vomiting that occur in the first 1 to 3 days after vaccination is reactogenicity. We allow for some a level of that because we know that the immune system is doing its job. This is not necessarily related to safety or adverse events that are significant medical events. Sometimes reactogenicity can cross over into safety, but in general, we think about these things as different, somewhat overlapping, but as different. And so we allow people to feel unwell for a little bit of time because we know that it's mild to moderate, we know that it's self-limited, and we know that it's going to lead to protection from COVID, which is the overall goal, of course. So some questions that I get a lot about vaccine safety that hopefully you all are answering as well. People often say mRNA vaccines are new. Shouldn't we have more safety data? Well, over 70,000 people received these vaccines in clinical trials, and there were no clear safety signals. Millions of people have now received these vaccines under the emergency use authorization, and there are no clear safety signals, although I know that CDC is very carefully looking at the anaphylaxis cases that are being reported. Does mRNA integrate or alter human DNA? Absolutely not. Messenger RNA remains in the cytoplasm. It's translated into that spike protein by the ribosome, and then it quickly degrades thereafter. It doesn't enter the nucleus. It cannot alter human DNA. These vaccines were developed at warp speed. They can't be safe. Hopefully, I convinced you that all of the safety steps were followed. They were just done in parallel instead of in sequence. And so rest assured that we have significant safety data about these vaccines. We don't know about long-term side effects of COVID vaccines. Well, as I told you, long-term side effects of vaccination, they aren't really a thing. The vaccine material degrades very quickly. What remains is your immune system remembering the pathogen, and that is fantastic. Some people have equated these COVID vaccines to the Shingrix vaccine, which prevents shingles. I think some of us know or have heard about the horrible pain that people can experience, especially in their older years or if they're immunosuppressed associated with shingles. The Shingrix vaccine is also a very reactogenic well for some time period after they get the Shingrix vaccine. But most people would say, I'll go through that if it means I'm not going to get shingles when I get older, because shingles can be a terrible thing. Same thing for COVID. We should reactogenicity to prevent COVID-19. Finally, the vaccine makes people sick. I think we kind of addressed that in the last point, but transient symptoms after vaccination means your immune system is working, and that's a really good thing. Immunologic memory is a great thing. But that's not to say that side effects and rare side effects are not going to happen. There's 7.7 billion people on the globe. We hope that that many people are vaccinated. Some will experience side effects. Some will experience very rare side effects. We need to be knowledgeable about that and be prepared for that. That these rare side effects will occur just based on the sheer number of people that are going to be vaccinated for COVID-19. And so, as I said, and I'll turn it over next to the CDC folks, there is continued safety monitoring ongoing. VAERS, or the Vaccine Adverse Event Reporting System, that has been in place for years and years, is how HHS and CDC have followed vaccine adverse events previously. And hopefully the 60% of you that have already gotten your COVID vaccine heard about the vSafe new app where you can record your side effects after COVID vaccination. And I know these data are being collected and analyzed frequently so that we can understand better about vaccine-induced side effects. And so we will hear more, we will know more. We just have to wait for those data to accrue and be analyzed. So I am going to stop there and turn it over to the next speaker. Thank you so much for your attention and for all that you do.
Colleen, thank you so much. And I know quite a few questions have come in the chat. I'm just looking at two that maybe while on it. There's one from Martin Luther to everyone that says, do we know how long the mRNA lasts? You'd mentioned the quick degradation. And this person says they understand it breaks down after production of spike protein. Is there any additional detail you can provide there?
Yes, I believe, if I remember correctly, I may be wrong in the exact timeline, but I believe the half-life is about 10 hours. So it's hours. It's not days, it's not weeks. The mRNA degrades fairly quickly after production of the spike protein.
Thanks so much. And just one more, and then we'll keep the flow going here. But from Stephanie Spencer, how much surveillance COVID testing of any type is being done with trial participants?
So that's the rub. So almost none. So the outcomes of these trials was symptomatic COVID-19 disease. And so there was very little surveillance testing ongoing in the trials as currently designed. That's to say, now that the trials are being unblinded and people are being offered who got placebo are being offered vaccine, and people who got vaccine are coming back in for surveillance. There is a little bit of surveillance that's been added to the trials, but in general, they were not designed to detect asymptomatic infections. We will have some data on that, but not the plethora of data that one might want from these trials for that outcome. And that's why it's still important that we, even after vaccination, we wear a mask and keep our distance. We've got to see community transmission come down to some degree before we can feel any sense of relief from the pandemic.
Thanks so much, Dr. Kelley. And feel free to answer some questions in the chat. We'll try and chat
Okay.
through some at the end as well. We're
Mhm.
going to transition now, but before we bring in our next speaker, a lot of this has been about understanding the vaccine, and many of the providers, healthcare providers on the call have gotten. But we did want to put a question out to the audience as the story continues to move forward, and we start talking about patients and conversations with patients. I want to put a question to the audience, which is, have you had a conversation with a patient in your public health clinic? Maybe it's your TB clinic. Lots of you wear different hats, maybe your HIV, STD, or hepatitis clinic. Have you had a conversation with that patient about COVID vaccine? Um, and I think we all are very empathetic that there's many topics that get covered in a clinic visit. So whether it's an acute visit for a problem, or whether it's a preventative visit, or whether it's a return visit or a new patient, have you all been talking about COVID with your TB, latent TB, or other patients? So it looks like 60% of folks are. Here, let me put this up, and about a third have not. Let me see. Perfect. So you guys can all see that. And And just to introduce then our next speaker to kind of speak to some of these things where some questions may be coming up amongst healthcare providers, but as again, this story moves forward, as Dr. Colley provided, let's hear from Dr. Sarah Mbaeyi. She's a commander in the U.S. Public Health Service and has worked as a medical officer in the National Center for Immunization and Respiratory Diseases at CDC since 2011. During her time at CDC, she's worked both domestically and globally on vaccine preventable disease surveillance, evaluation, and policy. She currently works in the center's Office of Vaccine Policy, where she leads work related to vaccine confidence and vaccine policy. And as part of CDC's COVID-19 Vaccine Task Force, she served in various leadership roles, including coordinating CDC activities around routine vaccine services, co-leading the ACIP COVID-19 Vaccines Work Group, and currently leads clinical guideline development for COVID-19 vaccines. With that, I'll turn it over to you, Dr. Mbaeyi.
Great, thank you so much. Am I sharing my own slides, or do you have them for me to go through?
Yep, feel free to take it over. If you have any issue, Amelia can show the slides as well.
Yeah, it might actually, if you could pull up the slides, that
okay.
I wasn't prepared.
No problem.
I don't have them right up in.
We can't imagine that you're busy these days.
Just a little bit. Sorry about that. Okay, great. So thanks everyone. So, Dr. Kelley gave a wonderful overview, and I'm going to now focus specifically on some of our clinical guidance around the use of these vaccines. Next slide. So just to orient you, we do have a document called the Interim Clinical Considerations for Use of these mRNA vaccines. This is where we house all of our kind of clinical guidance. This gets updated pretty frequently, about on a weekly basis. So there's a good chance that, any kind of questions that were common questions that we're getting that, over time we continue to update things. So definitely check back in for updates as needed. These clinical considerations cover kind of the gamut, including administration, vaccination of special populations, contraindications and precautions, public health recommendations for vaccinated people, and several other topical areas. Next slide. So first, just to start, as people, as everyone knows, Pfizer BioNTech COVID-19 vaccine is currently authorized for persons 16 years and older, and Moderna is authorized for those 18 years and older. They're both a 2-dose series administered intramuscularly. Pfizer BioNTech is administered 3 weeks apart and Moderna 4 weeks apart. These vaccines are not interchangeable with each other or with other COVID-19 vaccines. But either vaccine series may be used. ACIP doesn't state a product preference. We do have some guidance that we kind of put out last night that loosens this a little bit, for very exceptional circumstances, situations under which you could potentially interchange Pfizer and Moderna, but these are really should be rare and should not be done. These vaccines should be administered alone with a minimum interval of 14 days before or after administration of other types of vaccines. But again, in our guidance, we do have some language around situations under which you might need to administer vaccines within 14 days, like if somebody has a dirty wound and needs tetanus prophylaxis, tetanus toxoid vaccine, those kinds of situations. But routinely, they should not be administered with other vaccines. Next slide. So vaccination should be offered to persons regardless of their history of prior symptomatic or asymptomatic SARS-CoV-2 infection. We do have some data from clinical trials suggesting that vaccination is safe in these persons. We don't recommend any viral or serologic testing for acute or prior infection in order to make a decision around whether somebody should get the vaccine or not. Next slide. Vaccination should be deferred until recovery from the acute illness if the person had symptoms and criteria have been met to discontinue isolation. But we don't really have any strict minimal interval between infection and vaccination. This last bullet, we had an update come out last night that is slightly different from this. we do know that reinfection is uncommon in the 90 days after initial infection. And in fact, there's even more emerging evidence that it's uncommon in, 180 days after infection. So we kind of had language suggesting that people could defer vaccination if they desired. This was primarily due to, given that we're in the setting of very limited vaccine supply and how to maximize getting vulnerable people vaccinated. But we really don't suggest or recommend that people should wait 90 days to get vaccinated after COVID. Next slide. We also often get asked about, people with exposures in different settings. So in the, community or outpatient setting, we recommend deferring vaccination until the quarantine period has ended to avoid exposing healthcare personnel or other persons during the vaccination visit. For residents of congregate healthcare settings, such as long-term care facilities, we suggest that they may be vaccinated, as this would, vaccinating them, would likely not result in additional exposures, at least, as healthcare providers are already in close contact with these residents, and they should be employing appropriate infection prevention and control procedures. And for residents of other congregate settings, such as correctional facilities or homeless shelters, they may be vaccinated in order to avoid delays and missed opportunities for vaccination. But where feasible, precautions should be taken to limit mixing of these individuals with other residents or non-essential staff. Next slide. Also, in terms of people with underlying conditions, vaccine may be administered to people with underlying conditions who otherwise don't have any contraindications to vaccination. Clinical trials have demonstrated similar safety and efficacy profiles in persons with underlying medical conditions, including those that place them at increased risk for severe COVID-19 compared to persons without comorbidities. And we get asked all the time, what about this patient or that patient, kidney disease, lung disease, everybody wants to know the answer for like a specific underlying condition. And our response is basically the same, that people with underlying conditions can get the vaccine. And we don't necessarily have data in all these subgroups, but we do have to balance the benefits of vaccination in these people, despite not having specific data for every underlying condition. Next slide.
And so, yeah, Sarah, specifically to that point, you have a large group of TB and latent TB doctors here. So let me preface this by saying there's not necessarily a right answer, as there often isn't necessarily in these webinars. It does sound like there's one that maybe was suggested in our previous slide. And so we're going to work through that because Dr. Mbaeyi is going to go through some additional populations. But what would you counsel your patient completing latent TB treatment about getting vaccination? Oh, sorry. I think I have a different one here. Would you, let me see if I can pull up this one. Would you counsel your patient who is kind of at the end of latent TB treatment, you're seeing them in a clinic for a follow-up visit, would you counsel that patient to get vaccinated once it's available? So we're talking, perhaps not today, but you're in a situation where you got access to this COVID vaccine. A, yes, absolutely. B, no, I don't think there are enough studies in this subpopulation to recommend vaccine. C, no, I prefer not to talk about COVID vaccine with my patients until I'm more confident about there being enough supply. Or D, that's why I'm on this webinar. I thought you all would tell me what to do. And I don't know if you guys are seeing the poll or not. Oh, I see it. I see it up here. People are voting. Oh, this is great. I love it. I have oh, there's only two. There are only two options. If someone can come off mute and tell me if you can see all the options, or just one, or just two of them.
Just two.
There's
only two.
Okay. Let's see if we can. We might poll again. Maybe people's answers will change as we move through this. I want to make sure we've got enough time to talk with our experts, because I know you'll have so many questions. So we'll pause on that question while you guys think about it. I think maybe I'll put it back to Dr. Mbaeyi. If you were out in a latent TB treatment clinic, and what would you do? Do you think, would you recommend that patient get vaccinated in your own setting? And you can answer any of these.
Oh, sorry, was that for me, Nina?
It was for you.
Okay. Well, I am not a TB expert. I'll just put that out there. But I mean, we, in terms of at CDC, we wouldn't have any contraindication or any reason to say that patients completing LTBI treatment should not get the vaccine. Obviously, we have no data in this group, but I think where we kind of recommend, what people think about is, these patients, whether they have a risk of, SARS-CoV-2 exposure, whether they have, the risk of getting, severe disease or dying, should they, develop COVID-19, and weigh that kind of against these kind of unknown risks in certain subpopulations. So, and I also think the other consideration is, we do have limited supply right now. And if you do have a patient that for some reason, they're in the group, eligible to receive vaccine right now and vaccine is made available to them, if they turn it down now, when would be the next time they can get it? Those kinds of feasibility considerations would probably also weigh on my mind as a provider. So I guess my answer would be, I don't have a reason to say that they should not get it. Certainly with any vaccine, it's always, or any medication, it's always a discussion between patient and provider, but I think you really have to weigh kind of their risks and their risk of severe disease and so those kinds of things as part of the conversation.
Yeah, no, and keep going, because I know you're going to go through some populations, at least where you guys have given some more language. And while you're transitioning, I'm just going to read a comment here because it is just timely with the topic of from Thomas Bailey to everyone, who says, I'm already doing this. The issue is availability of vaccine, logistics of getting vaccinations scheduled. So many of our patients don't have email or smartphones, which is how scheduling is being done in my location primarily. And so that's definitely a real world perspective. And we'll open it up at the end too for folks to chime in with *6 to unmute. But keep going, Dr. Mbaeyi. Let's see some of the other populations you're talking about.
Sure. So in terms of immunocompromised persons, people with HIV infection, other immunocompromising conditions, or who take immunosuppressive medications or therapies, as everyone knows, might be at increased risk for severe COVID-19. As with many populations, right now, we don't have data currently to establish the safety and efficacy of the vaccine in these groups. I will say that people with controlled and stable HIV infection were eligible to be enrolled in the clinical trials, and there were some people enrolled, but there is no data in people with stable HIV right now, but potentially in the future there could be. But we, similar to our kind of guidance for just generally people with underlying conditions, these individuals may still receive COVID-19 vaccine unless otherwise contraindicated. But we do suggest that these individuals should be counseled about the unknown vaccine safety and efficacy profiles in immunocompromised persons, the potential for reduced immune responses, and the need to continue to follow all current guidance to protect themselves against COVID-19, which we still recommend, for everybody, not just people with immunosuppression. Next slide. In terms of pregnant women, again, pregnant women might be at increased risk for severe illness from COVID-19, and might also be at increased risk of adverse pregnancy outcomes such as preterm birth. And there are limited data on the safety of COVID-19 vaccines in pregnant women. Most experts, and this includes ACOG, AAP, kind of all the groups related to reproductive health, all support, and from expert opinion is that there's no reason to think that mRNA vaccines will pose a risk to pregnant women, and therefore, CDC as well as all of these professional organizations recommend that if a woman is part of a group recommended to receive vaccine, she may still choose to be vaccinated. Next slide. There are some considerations for pregnant women. This is a group that will particularly probably have a lot of questions and want to weigh the risks and benefits of vaccination. So some considerations might include the level of COVID-19 community transmission and their risk of acquisition, their personal risk of contracting COVID-19, either by their occupation or other categories, risk of COVID-19 to herself and her unborn child, the efficacy of the vaccines, what the known side effects of the vaccine are, as well as the lack of data about the vaccine during pregnancy. Next slide. So in terms of contraindications and precautions to vaccination, this is a little bit of a busy slide, and I won't go through everything in detail, but we've, people I know have heard or was mentioned about, kind of anaphylaxis occurring following vaccination with these vaccines. And it's still pretty rare, but we do want people to be prepared and, screen out the people that probably shouldn't get this vaccine. So we categorize people into 3 categories. Those that, have no contraindication or precaution to vaccination, that's in the green box. This includes basically all types of, allergies like food, food, pets, venom, environmental, allergies to, oral medications that don't contain vaccine component ingredients. So people have heard about the anaphylaxis. And so, people that had, a bee sting allergy, there've been a lot of concerns from a lot of people with those types of allergies. Can they get the vaccine or not? So we really tried to spell out that, most people with allergies can get the vaccine with no problem. If somebody's had, anaphylaxis due to any cause, we recommend a 30-minute observation period, otherwise 15-minute observation period for all other persons. Those people with a precaution to vaccination include people with a history of any immediate allergic reactions to the vaccines or to other vaccines, and so non-COVID vaccines or injectable therapies. So any, IV medication, IM, subcutaneous, or other vaccines not related to COVID-19. These people have a precaution, but not contraindication. So, kind of a risk assessment could be conducted with them. Again, their risks of COVID-19, what they're, balancing that against the unknown risks of anaphylaxis in these people, and those kinds of considerations. But if they do get vaccinated, they should have a 30-minute observation period as well. And then in terms of people who shouldn't get the vaccine, these are people that have had a severe allergic reaction, such as anaphylaxis after a previous, sorry, that's my 4-month-old. He woke up early from his nap. Who have a severe allergic reaction to any previous dose of the vaccine, any of its components, or people who have had an immediate allergic reaction of any severity to a previous dose of an mRNA vaccine or any of its components, or an immediate allergic reaction of any severity to polysorbate, which is not a vaccine ingredient, but there is potential cross-reactivity between polysorbate and polyethylene glycol, which is an ingredient. And so those people should also not get the vaccine. Next slide. And yep, that's it for me. Thank you.
Thank you so much, Sarah. And if you wouldn't mind trying to tackle some of the questions in chat, and like I said, we're going to try to highlight some of them, but we appreciate you so much as a resource for all of our clinic docs and healthcare workers. So with that, I'm going to turn it over to Dr. Brostrom. Dr. Richard Brostrom is a commander in the U.S. Public Health Service and also a field medical officer for Hawaii and the U.S. affiliated Pacific Islands. Many of you know him well. He's currently the CDC Operation Warp Speed Regional Coordinator in Region 9. He's an active member of the WHO Incident Management Team, and in that role coordinates integration of the U.S. API response with 22 member nations of the Pacific region. And he's been a subject matter expert for plans with the HHS Assistant Secretary for Preparedness and Response, the World Bank, the U.S. Department of Interior, the U.S. Department of State, and the Pacific Islands Health Officers Association. He's really been a champion for local testing capacity and PPE provision, ordering and receiving materials in the Pacific Islands, and has really developed models of the epidemic to guide procurement of various supplies. And I'm already seeing some questions in the chat that are a nice segue. It looks like from Julie Lowe, we're getting questions about, hey, how is production of the 2 vaccines going? And how many doses are in possession of the federal government? Are they ready to be deployed? So with all these questions and an active audience, I'll hand it over to you, Dr. Brostrom, to at least give us a lay of the land and kind of let us know what's going on.
Yeah, too many words already. Can you continue to move the slides, Neela? Thanks. I just have PDFs on my end. Great, thanks. I'm going to start with a number that I think we should all have seared in our heads as TB folks, and that's 2 million. And that's the death toll from COVID-19 this year already. 2 million deaths around the world, leading to the kind of response intensity, desperation in some of our cities, amazing amount of energy and budget properly put towards battling COVID-19. Many of us affected with close relatives or family members or friends that have gotten this disease or been troubled with it or may have even died from it. But of course, 2 million also rings a bell for us because that is the annual death from TB across the world as well. So COVID-19 deaths probably will exceed, or most likely certainly have exceeded TB deaths this year, but only by a little bit. And so I think it's important because I think US is getting we're not immune from COVID as we may be from tuberculosis in general. But I think the work that we are doing for TB is, equally important, and this TB control work has to be kept in perspective globally, especially as we battle COVID-19 this year. So let's move on from that stump speech. So next slide, please. Unfortunately, I have nothing to disclose. I'm not smart enough or crooked enough to be buying Pfizer or Moderna stock. Next slide. So the operation formerly known as Warp Speed, let's just go over a few of these slides and we'll go quickly because I think most of you are quite familiar with this. Next slide. So the goal actually is Dr. Kelley, what a phenomenal talk. Thank you, ma'am. And the courage to talk about structural violence and structural racism, I think, is really appropriate here. But she did make a mistake. She said the goal was to produce 300 million doses of safe and effective vaccines by January 21st. The initial doses are due January 2021, and those initial doses actually beat the target of as they were released in December of 2020. But the long-term goal is, of course, to deliver 300 million doses of safe and effective vaccines with the initial dose available in January. Next slide. And a few things to remember: that the safety, as Dr. Kelley so wonderfully pointed out to us, was always a top priority. And the name has been criticized because it may imply that some safety steps were skipped. And as she assured us, doing this simultaneously is what created the speed for the process and taking the risk out of the financial risk away from the large companies and having the U.S. pay for what they felt was likely good candidates and pay for it early, so production could increase even as the testing and then the phase 2 and 3 trials were ongoing. We know that some vaccines, multiple vaccines are being considered. Some were going to be ready more before others. And we know that 2 are approved by EUA and likely 2 more coming fairly soon. At least at first, the COVID-19 vaccines are going to be used under EUA. Next slide. This is probably the most important point, in that there's just a limited supply of COVID-19 vaccines before the end of 2020, but the supply will continually increase in the weeks and months. And probably one of the most concerning parts of this for folks or who are on the boots on the ground is that supply increase has not come as fast as anticipated. So the increase is more for months that follow, not necessarily the weeks that follow. And because of the limited supply, all of this great epidemiology and phase 1A and 1B and 1C and phase 2 and this rollout, which is so complex, it's all based on the fact that there's not enough vaccine. The goal is to get everyone vaccinated in the appropriate age groups as soon as possible. But all of the troubles here have been based on the fact that there just simply isn't enough vaccine coming, and it's not really within the powers of USG at this time anyway, to really make vaccine appear much faster. The companies are going as fast as they can. Next. At first, the vaccines may not be recommended for children. I think, as Dr. Kelley pointed out, it's just the trials should be commended for its inclusiveness, really remarkable inclusiveness, which is going to lead to better acceptance and success with the vaccine. But as often happens, the trials for pregnant women and children come later. Number 7, and let's not forget this, cost is not going to be an obstacle, and so vaccine continues and will continue to be free. Some places will charge an administrative fee to give you the vaccine, but the vaccine itself is delivered for free, and that we're trying to do our best to be as transparent as possible and update folks as soon as information is available. Next slide. Okay, I show this slide for a couple of reasons. This was cleared. This is my cleared slide, so it's dated. You see January 14th on there. And I was going to replace it this morning, but then I decided, you know, when I looked at the new numbers, I think there's a story to tell here. In terms of total doses delivered, it was 30 million a week ago. It's now 38 million. And that is the pace at which a vaccine is being released. Between 8 and 9 million doses a week, 4.3 million doses of Pfizer, 4.3 million doses of Moderna are coming off the line and are being distributed in a painfully equal, fair method based not on epidemiology or even based on demographics for age, but are being distributed by population only. That's even true in the islands. So that number is not surprising. It bumped up by about 8 million. But when we look at total doses administered, that number went from 11 million to 18 million. So there's a 40% increase, nearly 50% increase in 1 week, even though the doses are still sort of coming in at their pace. And what that indicates is that the states are, you know, this process, which was looked to be stumbling out of the gate during the week of Christmas, during the week of New Year's, the states seem to be able to pick up the speed now and are placing vaccine pretty much at the rate that it's coming in. There's still early backlog that's being used, and some of them are being used at large pods, such as football stadiums in Atlanta or in Arizona. But in general, the machine is starting to hum a little bit better. The number of people receiving 1 or more doses was 9.6 million, and that number this week is 15 million. So once again, 50 or 60% increase in 1 week. And the number that have completed vaccination at 1.3 million has doubled and is now 2.4 million in just 1 week. That's doubled. So, you know, I think folks were quick to point out the troubles for starting this complex, difficult endeavor, and rightfully so. But I do think the system is beginning to move forward in a way that's more efficient, and folks are learning how to do this at the state level, and more attention and more assistance is coming. But in general, I think this goal of 100 million doses in 100 days, if we look back even at last week, 3 of the days last week, we achieved more than 1 million doses per day. So it's quite likely that that goal will be far exceeded. Next slide. Oh, the other thing I'm sorry, one more point with that last slide, if you go back. I do have the privilege of working with the vaccine pillar for WHO in our region. We had our meeting yesterday, and their goal for the COVAX facility, which many of you have heard about for our region, is to deliver 0.25%, 1/4% of vaccine to be delivered to the poor countries in the Pacific before the end of February. And so I think it's important to keep in perspective the position we are in the United States right now. We are heavily affected, inordinately affected by COVID, but our access to these vaccines is quite a luxury. and this goal of 0.25%, we've already got 30 times that goal delivered to the United States already. Okay, next slide. So what's our role in the clinic, which is supposed to be the focus of this? And we talked about the 3 W's of wear a mask, watch your distance, wash your hands. To get vaccinated and protect ourselves. The vaccine hesitancy around this vaccine is real and significant, but we do have a absolute Cadillac of a vaccine. Maybe we're lucky, maybe we're better at it now, whatever. The vaccine is remarkable. And we're finding that some of the initial hesitancy, which was as much as 60% in some states among healthcare workers, is beginning to melt away, although there's still plenty of holdouts of folks who don't want to get this vaccine. I think it's important for us to be leaders and encourage our staff to get vaccinated, to say the words, to talk about it, even in the midst of a busy TB clinic, to help to enable access for the staff to get the vaccine, to advocate whenever you can, especially staff who are older or who have comorbidities. But certainly with patient care, we don't want our clinics to be a center for COVID spread in the community. And then encouraging our patients to get vaccinated. This is a little tougher to do. It's under emergency use authorization. And so some folks may feel a little bit reluctant to be advocates for pushing a vaccine on our patients. But I think individual counseling is certainly in order here, as well as signage in our clinics and encouragement of the 3 W's. Next slide. Here's one of our calls. We have weekly calls with all the islands, all 10 of them, hour-long calls. This is, I think we're asking about who's afraid of getting the vaccine here for our initial call. This is a picture taken in Yap Island from our conference, our Zoom conference, and we have the president of Yap and the health directors and some of the chief clinicians, and you can see there's lots of hesitancy. When we finished, we asked who was ready to take the shot, and everyone raised their hand, of course. And Yap has had a phenomenal rollout to date, with the governor being the first to get the vaccine. Next slide. So just quickly, I think it's important to understand the biology between COVID and TB. And here I'm not going to talk about the linkage between what happens to TB patients when they get COVID, or COVID cases if they have TB. I think that literature really is beginning to mature. We're starting to see articles being published, and certainly significant. We also we're told initially about the concerns that there are going to be maybe 6.3 million more cases and 1.4 million more TB deaths due to the pandemic and its ability to take us off our course of TB elimination, maybe setting us somewhere between 5 and 8 years behind from where we would expect to be. And so this is a great challenge for the global TB community. But I also want to talk about the social links between COVID and TB. And then the third thing is to fight the fake news. And I think it's important for all of us to be woke a little bit about what's happening for our patients, for our staff, even in this battle for unprecedented battle and new challenges for getting the proper facts. Next slide.
For sake of time, we'll just have folks maybe put in the chat any vaccine myths or misperceptions you're hearing about. But Dick, keep going.
All right, I'm almost done, because we do want to leave lots of time for conversation. One of the questions I deal with all the time, and I think this highlights the biology and the social, mostly the social risk factors for COVID-19 and our TB clients that we're seeing in the clinics. And of course, for me, I'm always going to the US Pacific Islands. So one of the questions that we are always answering is, are the US Pacific Islanders at higher risk of morbidity or mortality from COVID-19? And if you look at CDC data, you'll see that among Native Hawaiian Pacific Islander community, or the Asian Pacific Islander community, in that waste basket of a ethnicity category, where folks from India or Philippines or Japan or Chuk are all sort of tossed into the same category, we see that there really isn't any increase in risk. I see that Terry Chorba's mentions there's no COVID, and yeah, yes, you're right, Terry. And so that point is that to look at this, whether there's higher morbidity or mortality, we have to actually look at what's happening in the mainland. The jurisdictions are the last jurisdictions on the planet that are COVID-free because of amazing, brave decisions made to shut down travel, really far-reaching and difficult decisions made by public health leaders. They've really put a bubble over their island and have very strict quarantine measures. Next slide. But if we look in Hawaii, where all of these Asian and Pacific Islander categories are not mixed, where they're split out, we can see that red line, which is just so striking, is the rate of COVID-19 in Hawaii by ethnicity. Guam's looks a lot like this, as does the lines, if drawn properly, in many of the United States locations. So we see that COVID-19 is hammering these same populations, and some of it are the same risk factors: diabetes, of course, especially poorly controlled diabetes, but also crowding, access to healthcare, and of course poverty, which are the real risk factors here. Next. This is from an MMWR from Northwest Arkansas, where there's a large Marshallese diaspora. And we see the tiny blue bars there are the relative rates of getting COVID-19 or being hospitalized or dying from COVID-19. And in the green bars, you see the rates among what we know is a very high risk category. And those are folks of Latino descent who, and this has become a clear goal for the United States to reduce this disparity. And then we have this sort of silent disparity that simply doesn't get enough attention, and that is what COVID-19 does to the Pacific Islander population, both in cases, hospitalizations, and in deaths. This is, they're just really, this has been a terrible outbreak for those. And we look back now to the brave decisions by these islands to put themselves under very strict quarantine. And while we cannot count what we prevent, we certainly can see what has happened when this disease has gone into Pacific Islander communities in the United States, and it's awful. Next slide. Again, these are the risk factors for COVID-19, and as it crosses over between TB, especially we see diabetes, chronic kidney disease being two of the major risk factors that cross over. Next slide. And it's uncontrolled diabetes, of course. Here's a study from, I believe, in Italy early in the outbreak that demonstrated that poorly controlled diabetes was really the risk factor for COVID-19 deaths. Next. This is my favorite cartoon for the vaccine and how it works. We use this one for the Pacific Island populations when we're talking to them. I think it's nice because it does show that the vaccine cannot cross that line, doesn't have the key to get inside the nucleus or affect our DNA, and that it stays and degrades in the cytoplasm. Next slide. Finally, we have to educate ourselves, and we're gaining a great amount of really useful communication tools that CDC is putting out. We have developed another repository for this kind of information and posters, et cetera, in our region for Region 9 out of HHS, which also has the U.S. Pacific as well as the state's communication resources. Take some time and take a look at these. And these posters should be up in our clinics, right? Next slide. Here's a poster. I believe this is in YAP because we're talking about outreach for the communities as well. Next slide. And finally, here's the Marshall Islands for a few weeks ago when they got their first doses of COVID-19. There's the Secretary of Health on the left, and there's Frank Underwood, the TB director, getting his first shot as well on day one. Great work on our islands getting vaccinated. They understand how important this is. I had planned to share a series of some of the fake news and the memes, the information that's coming off of Facebook, off Instagram, off Snapchat, that our patients are seeing, that our staff are seeing, that run contrary to the facts. And they can be, showing them can be inflammatory or deemed political. And so I'm not going to show them, but I would strongly encourage you to take a look to see what it is your patients are seeing, what the other side is saying about COVID-19 and the vaccination process. We need to really educate ourselves. It's an unprecedented time of where people are getting information from wild, frankly, nefarious sources. And so we can't blind ourselves to what people are hearing and talking about. So please take some time, if you can, do a Google image search for COVID-19 fake news or COVID-19 memes. I think you'll be surprised at what you see. They're fairly sophisticated. Some are silly, some are funny, some are kind of scary, but all of them are dangerous. And I think it's important for us to be educated as we become advocates in our clinic. With that, I'll turn it back over. Thanks.
Thanks, Dick. As always, you're an inspiration to all of us, and we appreciate you bridging the gap between COVID vaccination and these public health clinics and making it reality. I'm not going to let you get off the hook so quickly, though, because a few folks in the chat asked about a photo you showed where there were people without masks, and there was questions about that. Can you give us any context before we hand it over to Sarah Mbaeyi to help us with the marathon of questions that she's been answering in the chat as well?
Oh my goodness, yeah, I think that there was a one from Yap. It's terrible. Those people don't have masks. Their kids are going to school. They go out to the restaurant, which is packed, and that's because they're COVID free. And these decisions, which have greatly impacted their economies, these decisions which have stranded family members, frankly, who are out on medical referral in Hawaii or in the mainland and can't come home now for almost a year. It's been at great cost, but it does, they don't have to line up 6 feet apart to get their vaccine. Life is attenuated there. Their economy is attenuated, but it's not threatened by COVID because they have 0 cases.
Thank you so much. And Sarah, I know we've had you in the hot seat over here in the chat. I just wanted to out loud, maybe for folks who are joining by phone, see if you could speak to some of the current hot topics that are on people's minds. A couple of people asked about the vaccines and the new strains, and if you could speak to vaccine efficacy, and or Colleen, if you want to chime in as well.
Sure, and I think Colleen was answering questions that I didn't realize she'd answered until I got down. So, but I think so far we've aligned on almost everything we've said, I think, which is good. So yeah, in terms of the variants, I think right now we don't have full information on that. I think a lot of experts suspect that we should still have effective vaccines regardless of these variants, but I think we just don't really have the data for that yet. There's investigations ongoing to look at that a little bit more. There have been some recent preprints coming out where people have looked at kind of the neutralizing antibodies and if those are effective against, the variant strains. And I know, one preprint from the UK suggested that they would be okay. There was some more concerns about the South African strain, but I would just caveat that with that, this is still an active area of investigation, and but this is something that will continue to be monitored closely.
Thanks so much. And Colleen, I'll kick it over to you, but if you can also address, there's a question about commenting on the Norwegian experience with the Pfizer vaccine and the elderly, which has raised some concern in the public.
I actually am not familiar with the Norwegian problem, but yeah, I think that the variant issue is definitely concerning, but no reason to panic yet. Viruses mutate, particularly RNA viruses mutate, and they mutate when there's uncontrolled replication, and that's what we have ongoing right now. So if we would like to protect ourselves against mutant viruses, we need to control replication. So we need to get community transmission down, and vaccines are one way of doing that. So time will tell. If someone wants to fill me in on the Norwegian thing, I can make a comment, or if someone else knows about it. I'm sorry, I'm not up to date on what happened in Norway.
No, that's fine. I think it's coming out from Dr. Al Lardizabal in New Jersey. Al, if you want to press *6 to unmute, or just unmute to ask.
Yeah, hi. Colleen, thanks a lot. Great talk. The experience they had in Norway was they administered this to about 29 or 30 elderly patients in a nursing home, and a good number of them had sort of passed away after they got the vaccine. And these were patients who were I think above 80 years old. And so there are people who have read about this and are quite concerned.
Wow,
I'm going to bring Sarah in. I'm going to bring Sarah in as well in case she's had more context around it.
I was just going to say that nothing like that has been seen in the US, despite millions and millions and millions of doses delivered. But yes, Sarah, what do you have to add?
Oh, sure. Yeah, I think I put this in the chat, or I meant to. I think it's important to understand that frail elderly people, they have a high risk of death, at baseline. I mean, they're more prone to kind of, that than other populations. And so I think it's really important to compare the rates to kind of the background expected rates, to kind of make that assessment. And, there will be a presentation at ACIP next week. So I would imagine, some summaries of that will be, shared in the press and things like that. But the bottom line is, FDA and CDC are looking actively at the safety data through multiple routes, kind of in real time, through VAERS, through other, systems, to do this through active monitoring, through, things like Be Safe, and things like that. And there's been nothing to suggest so far that we should make any changes to our recommendations for the vaccination of nursing home residents and very old people.
And Sarah, there is a question too that I'm hoping you might be able to answer that was generally about CDC efforts trying to reassure folks in communities of color or other at-risk populations. And certainly in a lot of our public health clinics, we see a lot of at-risk communities. Are you able to speak to that?
Oh, sorry, I probably missed if I missed that one. Yeah, there's actually been extensive work around that. There's kind of an entire team within the vaccine task force at CDC kind of focusing on that. Equity is certainly a huge component. We do have resources, toolkits and things like that on our website about addressing vaccine hesitancy in general and inspiring vaccine confidence that, we've gotten a lot of feedback have been really helpful. And there's been specific outreach in communities of color to try to share this type of information. There's also, I think just been a large effort throughout, from how, how the vaccine policy is developed through kind of, distribution efforts and things like that to make sure that communities of color don't get left out. So there has been a big focus on equity, but in terms of especially how to inspire confidence in the vaccines, a lot of our toolkits that we have on our website about this are, have that in mind, specifically the concerns that are raised in communities of color.
Thank you so much. And I know that we only have a few minutes, but we have a question that I know is burning on people's minds in terms of some of the logistics around vaccine administration. There's a question from Lynn about if the patient completed 2 doses of COVID vaccine, can they get adult vaccines like tetanus in between first and second doses, or whatever guidance you can give us about specifically other vaccines?
Yeah, so we generally, we don't recommend that COVID-19 vaccines and other vaccines are administered within 14 days of each other because we don't have safety or efficacy data on that. That wasn't studied in the clinical trials. But we do, there are situations in which we think that the benefits of vaccination would outweigh any unknown risks. It's all theoretical risks. We don't have any data to suggest that it wouldn't be safe or effective. So I think routinely you probably wouldn't want to do that, but if there's going to be barriers to vaccination, then that would be a good reason to do it. So for example, a situation we've heard about often is, somebody gets discharged from a hospital and they got influenza vaccine when they got discharged, but they got discharged to a SNF. And now in those areas, like a long-term care facility, those types of areas, COVID vaccines are being offered. And we don't want people not to get their COVID-19 vaccine because they've just had influenza or something like that. Other areas that may come up are, if like, a pregnant woman who's interested in getting COVID-19, but is also due for her Tdap, or, something where there's maybe some time limited considerations, and you don't want to create a barrier so that that person doesn't get it. But I think in general, we would discourage people from kind of routinely doing that at this time, just because we don't have data yet.
Thank you so much. And right along that vein, I know we're in the last few minutes, so mostly for people who are able and willing to stay over, but we recognize as a TB audience, and there was a question about TST and I to the COVID-19 vaccine. I would love to hear thoughts from any of our TB Center of Excellence PIs who want to comment. From a CDC perspective, we did put the lack of data around this area, but recognizing that there is a theoretical impact that the vaccine could have on decreasing immune response with a TST or IGRA. And so generally recommending about a 4-week window if the things can't be given together. But if other folks want to chime in or comment, that would be great.
Hi, Neela, it's Lisa Chen, and congratulations everyone for a really great webinar. I just want to add, I think people, Terry Chorba did send out a great Dear Colleague letter, and I think it spells things out nicely. I know you're probably all getting questions. We are, and I think that that's a great reference, number one. And number two, I think that there are really practical things that I've heard from our nursing colleagues, particularly who excel in being practical. And so for a lot of the situations where the question is coming up, remind people that they can, on the nursing home admission on day one, you can get your IGRA, or you could place a skin test. And 2 days later, when you're reading it, that's when you do that intake COVID vaccination. I mean, you can think of ways to just reduce any questions or doubts with the practical sequence and protocols in place. So there's a way out of this. and I love that the nurses are completely practical with this, and so it should help. And thank you, Terry, for a great letter, your colleague letter.
Yes, and it looks like Carla Winston from our division has put the link for that letter in the chat box. Thank you, Carla. I'm just reading out here from Henry to everyone regarding TST or IGRA. Should this be delayed after documented COVID infection, which might be more likely to impact the results through immune suppression than the theoretical concerns about vaccine? That's a great question, Henry, because that might be the more common thing we might see, documented COVID infection. I don't know if, I don't have an answer. I don't know if others on the call want to comment out there, maybe. Those of you with both a hand in TB and COVID.
Hey, this is Connie Haley at the SNTC. I agree with that. It would just be similar to any other acute illness where you may have, inability to respond appropriately. And as others have alluded, measuring the skin test and the IGRA is really measuring the body's immune reaction to it. So if your immune response is blunted from an acute illness or chronic illness or something else, then you might expect, even if it's COVID, that it would potentially make it difficult to detect TB infection if it's present.
Well, and remember that an IGRA has the indeterminate result. And so if you had an increase in background gamma interferon that could interfere, it would come back as indeterminate, or if you had a depressed reaction, it should come back as indeterminate. There may be someone who knows the mechanics more in their immune response and mechanics more with IGRAs, but we do have that safety net of the indeterminate result to help you decipher what's going on.
Yeah, and Lisa, that's true. And then along those same lines, if you perform an IGRA, we always recommend that patients, or I'm sorry, that providers read the quantitative values. So if you look at the patient's mitogen response, which should be their ability to respond to the antigen, if that's a really strong reaction and they have a negative, a negative TB1 or TB2 minus nil, then you can assume they've probably got a strong enough immune response to detect the TB if it's present. But I think by far the easiest thing is if it's preemptively to delay and to wait. Sometimes things happen and they call you after the fact, so you don't get to make those choices.
No, thanks so much, Connie. And we'll just wrap up with a closing comment about the same thing, that Ami Patrawala, one of our TB docs, very much in the ICU when these COVID patients were getting sick. She said she saw plenty of positive IGRAs in the setting of acute COVID illness during her March and April surge. So we know that this is an ongoing story, as it always is with these expert network meetings. Keep in mind that we've got both the recording and the slides available for sharing. We really appreciate you joining today, and feel free to send messages about future topics you'd like to see over the course of 2021. Thank you so much, all. Have a wonderful rest of your weekend.